Okay, everyone, we are covering the last metabolic disease that we're going to focus on in the class, which is diabetes. Now, I put up a couple of videos, one a little bit on the etiology and kind of give you the cellular level of what's going on. And I love the visuals on it because I'm a visual person, so I hope you enjoy that. And then I also put up another video on the focus of exercise and working with diabetes and the impact of exercise. And she does go into a lot of the research, which I think is really cool. It's a little bit dated, so I'm going to give you some updated numbers, but I think you should hear some of the consistent messaging and again, repetition, getting you this knowledge in different forms that you guys are kind of staying with it. Again, I'd recommend printing out the note sheets to this as we go along, and you can make some notes. So I am going to share my screen. Going to share here, share, and boop, boop. All right, here we go. So globally, we know diabetes is a major health condition worldwide. In 2025, from the International Diabetes Federation, 11% of the world's population, those 20 to 80 years old, are living with diabetes. And they are predicting over 4 in 10 individuals might be unaware that they do not have this condition. By 2050, they are predicting close to 850 million people living with diabetes, increasing 46%. So this is continuing to increase, and it is driven by several factors, including socioeconomic, demographic, environmental, and genetic factors. So those people who live in more urbanized areas, aging populations, those decreasing those physical activities, all are at risk for diabetes. It is the 8th leading cause of death, and is the #1 contributor to kidney failure, lower limb amputations, and adult blindness. The medical cost is off the chain. Worldwide, it is $966 billion annually. This is a very costly disease. And those people who have diabetes, their medical costs will be twice that of people who do not have it. So you get it, worldwide, it is a major issue. Within the United States, we have close to 30 million people living with diabetes and 10 million people who are not undiagnosed. But more concerning, we have close to 116 million people who we consider pre-diabetic. We're going to talk a little bit about what that definition is in a couple of minutes. But generally, diabetes is a term used for a group of disease that is indicated by an elevated blood glucose level, hyperglycemia. So it could be by the insulin secretion or the inability to use insulin correctly. We're going to kind of go into this, but why it is so important is it contributes to the #1 cause of death, which is cardiovascular disease, and it also contributes to other issues such as dyslipidemia kind of complicates it, inflammatory markers complicate it. So this, again, the metabolic diseases kind of all parlay off each other, and it is a major concern. We're going to kind of go into the different types of diabetes next. So you have, there we go. Have heard of type 1, type 2, and you probably heard of gestational and other origins. So we're going to kind of talk about those a little bit. We know when your body breaks down food that you eat, it turns into sugar or glucose, and it's released into your bloodstream. When your blood sugar goes up, it signals to your pancreas to release insulin. Insulin acts as a key to let your blood sugars into your body cells to be used as energy. Now, this is complicated because sometimes the system is broken down. In type 1, it's an autoimmune disease that is the destruction of the insulin-producing beta cells of the pancreas. It does not produce insulin, therefore resulting in insulin deficits. Most commonly, we see this early in children, or even in teens or young adults. There could be some residual there. It could be combined with some of the other. Type 2 diabetes is driven by insulin resistance in the skeletal muscle, adipose tissue, and the liver, or a combination of both. And that's where insulin is out, but it's not its action to uptake or to facilitate the uptake of glucose into the cells is not working. Most of the diabetes is this type of is this kind. We also have gestational diabetes, which develops during pregnancy with women who've never had diabetes before. And if you have gestational diabetes, your baby could be at risk for health problems later. Gestational diabetes goes away after pregnancy and resolves. However, you have an increased risk of developing diabetes later in life. Babies who are more likely to be obese is if you have gestational diabetes, your child is more likely to be obese as a child or a teen, or to develop type 2 later in life. Diabetes is not a single disease, but it's a group of disorders shared with the feature of hyperglycemia. The underlying defects lie in either insulin secretion, insulin action, or both, as we just talked about type 1, type 2, and gestational. Other origins, when we talk about this, is the monogenic or specific types, the maturity onset diabetes of youth. So this MODY is a gene mutation which pinpoints a precise mechanism. So it could be insulin sensitivity or regulation. There's usually some kind, it's a genetic disorder on a specific gene, and I will not make you go into it, but understand that, you know, sometimes folks have this disease, some of the gene disorders just causes somewhat of hyperinsulinemia, hyperglycemia, and that's how they normally run. Some completely throw off the system. So with those 4 different types, the primary, secondary, gestational, or secondary, we kind of understand that the majority is type 2 diabetes. All of them, different cluster of diabetes is a group of them. So just to let you know. And then some common symptoms that you will see with them. Folks are typically hungry, thirsty. Sometimes they lose weight unexpectedly. They have numbness in hands and feet, frequent urination, extreme fatigue, sexual disorders. So, but what this progresses into is some major complications being slow wound care. And it's going to come back, and we need to know this as exercise physiologists, because we're going to have to keep in mind when we're working with these types of patients. Peripheral neuropathy. They can't feel their feet. We need to know this if we are working with them. Cerebral disease, diabetic neuropathy, eye damage, as I mentioned, #1 cause of blindness in adults. So really important for us to understand the complications associated with this disease. With type 2 diabetes, there's other things that increase one's risk for, and it's just not just obesity. It's obesity, impaired glucose tolerance, resistance, ethnic background, sedentary behaviors, age, family history, polycystic ovary disease can kind of contribute to it. So a lot is going on here. But let's talk about the different diabetes. All right. I mentioned the 3 types, but I mentioned 4 types. I need to mention a 5th type, pre-diabetes. Pre-diabetes is a term used for those whose glucose levels don't meet the criteria, but they are well on their way and actually have an increased risk of developing diabetes. So it is a precursor, and we like to identify early so they do not develop this disease. As I mentioned, in the United States, there's close to 117 million people walking around with prediabetes. If we can get to them before they become diabetic, that would be wonderful. So, so kind of going through, we already talked about what it is, what symptoms they have, and what complications are associated with it. Let's go over the criteria. So for normal to be considered not diabetic, your fasting blood glucose would have to be under 100 milligrams per deciliter. We will be testing this in class and you will see where you're at. That's why I'm asking you to come in fasted, 12-hour fast. Sometimes they will do a plasma glucose level, and they commonly will do this with gestational, usually around 20 weeks. The female goes in and they have to drink this awful drink, and then they have to wait 2 hours. And if her plasma glucose level is under 140, that's great. So if it's under the A1Cs, which is more of a long-term look at one's glucose levels, is using the A1Cs. So under 5.7, under 100, or under 140 for the plasma, you are good to go. What happens when one's one like 99 or 5.6? Again, that goes into our 2.0 versus 3.0 healthcare system, as Dr. Pia Tieta will mention. Prediabetes, fasting glucose 125 or 100 to 125, plasma glucose 140 to under 200, and the A1Cs 5.7 to 6.4. And what is the threshold for diabetes is over 126 for fasting blood glucose, plasma over 200, and A1Cs over 6.5. That's when you're considered. Now, do know, prediabetes, there's a strong association with A1Cs and subsequent diabetes. But there is, the 5-year risk. Those people who are hitting from 5.5 to 6 have a 5-year risk of 5 to 25% higher than those who are lower than that. Those people are hitting from 6 to 6.5 have anywhere from a 25 to a 50% increase. So we know the higher it is, the higher risk that they have. Diabetes, the World Health Organization and other organizations define lower fasting glucose levels, such as 110 versus the 125. So again, I think looking at the whole package, family history, age, gestational diabetes should all be taken into account. So this whole prediabetes, and we're going to talk a lot about prediabetes. Are you at risk for developing prediabetes? There are 7 questions that we typically ask. 1, your age. We know as you get older, you have an increased risk. 2, your gender. Men have higher risk, especially middle-aged men. If you are a woman and if you had gestational diabetes during your pregnancy, increases your risk. If you have a family history, such as immediate family, mother, father, siblings, something to that effect, immediate, then you're at higher risk. If you have high blood pressure, you have higher risk. If your weight category is in this chart, and it doesn't define men or women, it just gives you the chart. So you can see if you score 5 or more on this, then you actually have a higher risk. And, you can see just by being 60, you get 3 points. So as you get higher, and then again, if you're 60 and you're overweight, and let's say you have 3 plus 3, you get 6 points right there. You could have none of the other features, but you could have that you're older and overweight, puts you at an extreme risk, high risk. All right, I've been babbling. Let's take a toss here. What is the range of A1Cs that indicate an individual has pre-diabetes? Should I play the music? I'm not going to play the music. But yes, if you said 5.7 to 6.4, not 6.5, then you would be correct. That's the right range. The other thing is, here's I'm going to put up a handout, or you can look up. You do need to be familiar with these terms, from the beta cells to alpha cells, understanding all of that. I will put that in our Wonderful Diabetes folder. So take a look at that so you are well versed on the terminology. All right, let me ask you another question. The effects of exercise. Exercise may lead to a stored muscle and liver glycogen, leading to a higher blood glucose level after exercise? What do you think? Well, let's think this one out. During exercise, stored glycogen may decrease since it's used for energy. The process of replenishing glycogen helps reduce blood glucose. So you release glucose out of muscles and liver because you're exercising and you need it. But after exercise, you need to replenish those stores. So your actual blood glucose level should decrease. Okay, you're walking with me. All right. Insulin resistance results when beta cells in the pancreas cannot keep up with the demands of insulin needed to balance blood glucose. Well, eventually beta cells in the pancreas will become fatigued. They no longer produce enough insulin to regulate excessive levels of blood glucose. This results in a decreased beta function, hyperglycemia, and ultimately type 2 diabetes. So insulin resistance results in it's false. Insulin resistance results when beta cells in the pancreas cannot keep up. They become fatigued, so they stop producing. They're not trying to keep up, like we don't need more insulin. They're just not producing the insulin. So I hope that makes sense. Okay. Physical activity is essential in maintaining normal blood glucose levels and preventing and managing prediabetes and type 2 diabetes. Accumulation of pancreatic fat is reversible by moderate intensity exercise and high intensity exercise. So this is good news. We could do some major benefit to the body, especially with folks who have prediabetes and diabetes. So we could reduce the accumulation, decrease pancreatic and visceral fat, which is huge. It improves beta cell functioning. So again, remember, a lot of times it's insulin resistance that's going on, but we can also improve the beta cell functioning to release that insulin. Physical inactivity increases energy. It also addresses physical inactivity because we need energy expenditure and muscle function. It also has a benefit for those folks who are overweight and obese because it prevents excessive weight gain and regain. It also has a benefit on cardiovascular risk factors. It improves your blood glucose, your blood pressure, your vascular function, and reduces low-grade inflammatory response, you understand. And then, of course, it can actually increase insulin sensitivity too. So all kinds of great stuff going on here. And we can see it's possible to prevent or delay diabetes into type 2 with simple, proven lifestyle changes. This is an important message to share with your clients. So just because they're pre-diabetic doesn't mean they have to be diabetic. Risk factors below may increase the risk. So we have, what it can impact. It can help with your normal blood glucose. It can help with prediabetes. It can help with diabetes. It can go back. So, it could reduce the risk by decreasing the risk. So I kind of put these kind of backwards, but basically exercise, diabetes will kind of be complicated by the increased risk, but we can also decrease the risk by addressing the following. Okay, there is over 200 publications on the National Diabetes Prevention Program. This is a really cool, interesting study that they did. 27 centers nationwide ran the study, and you can go into the link, and I know the follow-up in our follow-up video that I put on there will hit on this video, on this study too. But I want to talk a little bit about it because it was so important, and it kind of got into some ethical issues with research. So they recruited over 3,000 participants to compare a intense lifestyle program targeting diet, exercise, and behaviors to metformin. We hear a lot about metformin right now, and a placebo group. So I wanted to share some of this study because it was so profound. So anyone who works in diabetes or in lifestyle management, this is a good one to be familiar with. The study found that to achieve and maintain a weight loss of at least 7% in the initial body weight through a healthy low-calorie diet, which was huge. When they did this study, they had that control group, and then they had the intervention group, and then they had, the comparison group. And then they finally had to stop the study because they were having such amazing results that it was unethical not to treat the control group because they were having so much good results with it. So sometimes, you think about, oh, well, we want to do a study and make sure there's no complications. Well, there's so many good things that it ethically wasn't right not to treat someone. So they also found that engaging in moderate physical activity, 150 minutes, was beneficial. Ultimately, the program was to prevent individuals from developing from pre-diabetic to diabetic. What they found was the incidence of type 2 diabetes was significantly reduced in all three groups, 31% reduction in the metformin group compared to the placebo, but a 60% reduction in lifestyle group compared to placebo. That's really important. The results make a compelling case for the power of lifestyle intervention. Now people are using the metformin and the lifestyle to kind of have even a better effect. So it was really important that prevent type 2 diabetes, that DPP lifestyle program, metformin and placebo is what they were investigating. And, they started this in 1996. That's why all the metformins right now and all the different GLP-1s are so popular. They've been around for 20-some, almost 30 years now. So it's not a new drug out there, but it has a lot of research that now is becoming more and more popular. So they also looked at 10 years outcomes. So the incidence of diabetes were randomly assigned to the lifestyle were was reduced by 34% compared to placebo. The incidence of diabetes in those who were randomized to metformin was only reduced by 18%. Overall, the lifestyle intervention was the most cost-effective program. So again, more people were able to maintain it compared to the metformin. Long-term results kind of persuade Medicare Advantage to offer this program to be covered under insurance. So you'll see this, sometimes they call it Prevent Type 2 or Diabetes Prevention Program, DPP. YMCA's offer it, health department offers it. A lot of people offer it. You can get trained. They actually offer all of this stuff openly. So if you're working for a YMCA and you want to do this, you can go to the CDC, type in that program, and it will give you a week by week. And we actually did this with the city of Statesboro with some of their workers. We just had a lunch and brunch group, and we did it for over a year. And it was interesting to see how it went, and it was very digestible, and it was baby steps for education. So this might be something that you want to print out and kind of, oh, I should talk about, portion sizes. I should talk about how to get fit. I mean, they literally did the whole lesson plans of how to do this, and it's open and available. So again, participants that are more likely to prevent or delay the onset of type 2 diabetes than those who took metformin. So this was huge. The program focuses on making lifestyle changes, including nutrition and physical activity. The diabetes prevention program is covered benefits for those who are in the Medicare program. And this program has been shown to help people develop those skills to maintain physical activity. It's really good. It's open, it's available. I would go on there And again, you can print out the whole workbook. And then they have the instructor workbook and they have the client workbook, which is really nice. So pre-screening and screening assessments. ACSM, following the pre-screening assessment and guidelines, make sure that you're looking for comorbidities associated with diabetes that can affect exercise. So when we're pre-screening, we're trying to figure out, oh, well, do they have coronary artery disease? Do they have cardiovascular disease, dyslipidemia, peripheral neuropathies, all of these different things that could be going on that could complicate things. With prediabetes, exercise prescription is the same as healthy individuals. However, it's important to screen for other medical conditions in case you need to modify, in case you need to understand what medications. Remember, in my training tips folder, I do have a one-pager that gives you the cliff notes on medications. Patients with prediabetes are generally not at risk for hyperglycemia. So that's why we go with the ACSM guidelines. But if they are on metformin, there's a limited risk of hypoglycemia. So be careful on that. Look up your medication list as good practice. Some considerations. The program should be enjoyable. So one, what do you enjoy doing? Do you prefer structured or unstructured activities, group or individual? So kind of figure out what they like. Number two, are there accessible medical fitness facilities? What are the programs available? Is there a YMCA? Is there someone that you compare them with? Pair individuals with leaders in this area who are passionate and compassionate for folks who have diabetes. Training with others who have similar medical challenges with knowledgeable staff is going to be really important. Three, make it a social experience. We've got to change their lifestyle. It has to be moved from very sedentary to, do you have friends or neighbors or coworkers? Who can you share these physical activity experiences with? Number four, what are you currently doing? Again, you want to make sure that you're keeping it simple. You don't want to go too complicated. You can't go from 0 to 60. You got to kind of take those baby steps with them. Number five, what would be convenient or accessible for you? Do you have equipment at home? Do you have access to a fitness center? These are types of questions that you should be asking of them. Include coachings to inspire, respectfully answer specific questions or personal questions. So, you got to figure out what kind of coaching do they need? Do they need a little bit more coaxing? Do they need you to be a cheerleader? Do they need you to reinforce? How do they want to be coached through their sessions with you? Can you describe an activity that makes you feel uncomfortable? Consider their limitations. So like, what do you not like to do? Maybe they don't want to work out during the busy time. Maybe they don't want to go do water aerobics, even though it's a great thing to help with balance, but you got to figure that out. And then you might want to say, do you have any devices or digital trackers that you want some feedback? Do you like technology? Do you just want me to send you a text? Do we want to do, something to interact with them to give them some feedback? So those are different things that you can help consider when you're walking through the program and setting up programs. High intensity interval training, very short high intensity interval training or power bursts during moderate intensity aerobic training may help maintain blood glucose balance by controlling the decline of blood glucose during early post-exercise recovery periods. So there's research out there that shows it is very effective for pre-diabetics with this moderate continuous work, but it takes less time and improves all this, cardiovascular fitness factors, their A1Cs, all of that good stuff should work. So consider easing into it. And, again, folks who haven't worked out, they might need longer, a shorter rest, exercise, rest, exercise. They can't go long durations. They need the rest duration. So it is kind of a high intensity, but it might not be what you consider high intensity for yourself, but for them, even if it's, their rest might be an active rest and it might be a full rest, not quite sure with it, but something easy and then fast, easy then hard, easy then moderate, something to ups and down with them, to help them with that. And there's a lot of research on that. So we have Dee Dee. I'll give you a case study. So Dee Dee, 54-year-old woman, enjoys cooking, knitting, community projects, and watching her dog play in the yard while talking on the phone with her friends. She's tried water aerobics at the community pool with a friend and actually loved it. Her height is, she's 5'5", 160 pounds, BMI 127. Her heart rate is 85, resting heart rate. Her blood pressure 125/90. Her blood glucose level, her A1Cs, her HDLs, and her triglycerides. So, all right. Now, go back to Dee Dee. So below age associated norms. So also like you did a fitness assessment on her and she was a little bit below her age norms, her time to sit, her upper body flexibility, her standing balance, especially her left leg, and within norms for her upper body strength and endurance, and lower body flexibility. Your observation is Dee Dee's breathing rate was heavy by the end of the time sit to stand, and she was reluctant to try the balance on her left leg. So let's break it down. What questions might you want to consider when developing an exercise program for Dee Dee? Think about this for a second. Maybe how can Dee Dee increase her physical activity every day during the day and week? Because we know this just can't be come to the gym once a week for an hour. She's got to change her lifestyle. What can she tolerate? What does she enjoy? She mentioned that aerobics. So how often might she be able to get to that aerobics class? Does she have any fitness equipment at home? That might be something that, hey, can we build this in, little exercises at night? Are there activities that she notices that increase or decrease her pain? So she's really reluctant on that left knee. So we wanted to, so what do you not do with it? So we kind of have to keep that in mind. And has she ever felt off balance or caught herself or fallen? And where does this happen? So is there like at-risk thing? Is there stairs in the house? Is it grocery shopping? Where is she, we might have a fall risk going on. So what strategies might we develop for Dee Dee? Well, we definitely want to focus on preferences and convenience with physical activity. We want to make things easy for her. So if she enjoys, she might say that that dog, instead of just watching him walk and run around the yard, maybe we can take him to the park. Maybe there's someone at work. We want to consider a home-based fit-in exercise that could include some skills such as mobility, helping her knee pain, her flexibility, and her balance. We might think about physical activity snacks. How can we get her moving through the day and use a tracking system? Maybe her phone should have, could teach her how to use that health app to count her steps. Maybe talking about going to the aqua aerobics with a friend, or even joining the pre-diabetic program, that diabetes prevention program at work or at home. So, all right. So how do we, how does this all work? So let's talk a little bit more about the crossroads of what is going on with the effects of exercise on insulin. So we know a single bout of physical activity may increase muscle glucose uptake by 5 times resting, which is awesome. Post-exercise glucose uptake remains elevated without insulin for up to 2 hours. So this is great. Shorter duration exercise, less than 20 minutes, that includes HIIT type of training, nearly 24 hours of insulin action. So this is good. So aerobic activity is having a lot of impact. So while they're working out aerobically 5 times, after exercise 2 times, and even longer durations for that high intensity, a full day after they've been working out, they're having benefits on their systems, on their insulin and glucose uptake. Looking at strength training and the effects of insulin action. So strength training, actually insulin sensitivity typically improves 10 to 15% with the research that we're seeing. Without the natural support of insulin, muscle contractions work like an insulin pump to transport blood glucose into the muscle, resulting in better blood glucose balance. Every contraction reduces the work of the beta cells. So the beta cells don't have to, preserving them so they are healthy enough to prevent the delay. And also maintaining muscle mass over a lifespan helps with weight loss and is critical for sustaining an active lifestyle that contributes to blood glucose levels. So strength training is really, really important. Staying active reduces sedentary times. There are additional structured exercises that you don't have to do. We're just kind of fitting it in. So just getting up and walking has a profound impact on your blood glucose levels. So 30 minutes uninterrupted sitting with 3 minutes of light to physical activity. So, what can you tell your client about, getting up and moving at work? Like if they don't, like right now, me sitting, oh, it's been 35 minutes. I wish I could get up. We're going to finish this. You can hit pause and get up and move, but it does getting little activity snacks throughout the day to, again, facilitate that blood glucose uptake, to take ease off the beta cells in the pancreas so they don't have to work as hard. All of that is a benefit. All right, exercise-related goals for pre-diabetics. So you definitely want to get them to control their glycemic effects. So talking about foods that spike your glucose levels. So, high glycemic index. Some of them who are pre-diabetic might have the constant blood glucose monitors where they can see when they eat something, is it spiking their blood glucose levels? Prevent insulin resistance with type 2. We definitely want to improve their glucose tolerance, maintaining a healthy weight. So these are things that could, be goals for them. We know that all of these things, from reducing blood pressure to improving their dyslipidemia, and other factors such as improving, the reducing risk of depression, all of these wonderful factors goes in to improve their quality of life. So talking about some of those goals with your pre-diabetic versus we're just going to avoid becoming diabetic, that shouldn't just be the overall outcome. You should look at other factors that influence. All right, so if we look at the recommendations, it's very similar, utilizing the progression that we need. Exercise, the EMI handouts can summarize the different components for individual exercisers, but again, 3 to 7 days. Again, if they are overweight, they might have to go up to that 150 to 300 minutes, but if they are normal weight, we can keep them, 3 to 5 days. But if they're struggling with their weight, do consider the comorbidities going on. Resistance training, flexibility, 2 to 3 days a week. Intensity, 50 to 80%. 8 to 10 muscle groups that we want to be hitting. All of the same good stuff. But again, think about what else are they struggling with. So HIIT training may be superior than continuously aerobic training, but consider the training modes that are best tolerated and most palatable for each client. The effects of physical activity increases with the increase of volume even low volumes such as 400 calories per week can improve insulin action for previously sedentary individuals. So if your baseline of exercise, you want to get them to the volume of 250 calories a week, you baby step to get there. Both aerobic and resistance training programs can promote adaptations that enhance insulin action, even without weight loss. So they don't have to lose weight to get the benefits of exercise, which is really important. Number 4, if better glucose control and the reduced risk of hypoglycemia, perform resistance training first and then aerobic training. Really important. We've kind of hit on this for several different reasons, but even with, to control their blood glucose better, go ahead and do that resistance training first. Clients should work with a coordinated multidisciplinary team that that supports their diabetes care, their education, their nurses, their dietitians, their mental health. So you create a team for them that they have a good communication, so they know, their doctor knows that, oh, well, you've been exercising. We should see some effects from this and some benefits. Might not be directly with lowering weight or something, but it could have a profound impact on their blood glucose control. Number 6, physical activity and exercise plans should be based on individual preferences, their goals, their values, and really tailored for them. Even though I told you about high intensity, if they don't like that, you might have to do a moderate intensity interval training and then get them to the high intensity. Individuals, for number 7, a support team can help formulate a management plan for them. Maybe some life coaching in there, because that's really, really important. And then you could explore some self-management programs and education that they could better understand, because it's a lot. So progression for the FIT principles with folks with type 2 diabetes. So aerobic, you might go a couple weeks light and then moderate to vigorous. So it is a slow increase. And resistance training, low moderate to moderate, as tolerated. So we want to see an increase. So when you gave me those training programs, I commented on a lot of your folks that you had no increase, no progressive increases. So that's what you need to keep mindful, that you don't want to increase too fast, but we should see some kind of increase there. And with the balance training, you might first have to address the flexibility and then increase to balance and stability, adding changes. We talked about changing your support from wide base to small base, short lever to long lever, open eyes to closed eyes, all kinds of different things that you can do. When we look at activities for clients with diabetes, you could also think about the benefits, and there's a lot of research that shows mindfulness activities. We actually have a Tai Chi here in Georgia, in Statesboro, in which Dr. Lee heads up for the community. So, mindfulness activity, it could be everything from understanding how full they feel to kind of listening to their bodies. Tai Chi and yoga could be great balance activity. Step counting is a wonderful way to show them, okay, well, let's look at your steps. When were you most active? I'm glad that you got your 7,000 steps, but it looks like you just got most of them at one time. Could we spread those steps out? Those are really important. Sometimes they like boot camp or different group fitness exercise to kind of keep them motivated and have that social aspect of it. Well-being. About 20 to 40% of those folks with type 2 diabetes will have some kind of negative psychological reaction. This is a major health condition, getting down on oneself, dealing with, physical and emotional stressors of having this disease. We have to teach a lot of self-compassion, a lot of, keeping positive, understanding that the actions that they're taking are making a profound difference when they're exercising, and understand that they're going to fall off. It's okay. People have setbacks, and how do you get through your setbacks? How do you get back on your routine? How do you take a little bit more control? So understanding, maybe even suggesting some stress reduction activities to help them, be a little bit more compassionate with themselves and kind of refocus. A lot of mindfulness. There's a lot of different things they can do for mindfulness. I'm not the strongest person on that, but, from journaling to, some meditation to a lot of different mindfulness activities can help them, and you can help them explore what will work with them. So when you are working with clients who have diabetes, it is really, really important that you ask them to inspect their feet before and after exercise, that they are wearing appropriate footwear, that they're not wearing poor shoes or, wet socks or anything like that, that they've got to have great footwear and inspect their feet, because, they are prone to, they don't feel their feet, so they could step on something that, a little pebble that you and I would feel, they're not going to feel that. And if you have a little pebble in your shoe and it rubs and it rubs and it rubs, you're going to have an awful, awful sore. That's why it's so important that they do some good foot care. Understanding the symptoms of hypoglycemia, very similar to hyperglycemia, but they need to pay attention if they're on a beta block, which can inhibit hypoglycemia awareness. So they have to just check for symptoms. They should keep their glucose close to them at the gym, the pool, wherever they're at. They do need to have a medical ID, because if they do go unconscious, people are gonna be like, what's going on? I don't understand why this person is unconscious. Hydration is going to be really, really important for your clients. So making sure that they're drinking before, during, and after. Dehydration increases the risk of hyperglycemia. And you've got to be careful on the heat. We are in Georgia, so maybe working out inside is a better plan for them. There are wonderful activity sheets from Exercise is Medicine, both for our pre-diabetics and both for our diabetics. Important for you guys to recognize that being too low, hypoglycemia, if their blood glucose is lower than 70, this can occur in people taking insulin or medicines that increases insulin, which increases the uptake of blood glucose. So that is a contraindication. So typically we want it anywhere from 90 to 250, their blood glucose levels. Some symptoms could be shakiness, abnormal sweating, nervousness, anxiety, tingling, hunger, all that could be going on. Other concerns, the risk is higher during or immediately following moderate intensity exercises and can continue for 12 hours. So a lot of times with our diabetics, we like to work out early in the morning because their hypoglycemia, low blood glucose, will happen post-exercise. And if they're sleeping, they don't know the signs and symptoms because they're out or at night or something like that, and they're at home and they could, so we don't want them being shaky, disoriented, any of that anytime, but especially if they're by themselves in their home. So they might have to adjust their food, their medication, figure out what time of day, usually in the morning, is best. Vigorous intensity and resistance training before, you need to perform that before aerobic training. It lessens the effect of the blood glucose lowering. It also reduces the risk of hypoglycemia with individuals with type 2. Best thing is to monitor the blood glucose. Nowadays, most people have a constant monitoring system on them. So for some prevention, so they should, if they come in, they should have had their meal, but if they didn't, they might want to have a small snack, 10 to 15 grams of carbs for low to moderate intensity exercise. That lasts more than 60 minutes, 30 to 60 minutes. Make sure they're getting enough hydration. Again, talking to them about understanding their levels, coming in and out, being very cognitive, whether they're measuring it on an app, whether they're writing it down in a book. They do need to be very cautious, especially if they're on different medications, all that kind of things, and perform resistance training before aerobic sessions. Another good reason. Hyperglycemia, so too high glycemia could happen before, immediate, or after exercise. Vigorous exercise of any type can cause elevated blood glucose. Remember, when you exercise, body releases stored glycogen, but then your body, releases more. So it's important to kind of regulate. Combining resistance training first, aerobic training second, optimizes your blood glucose stability. If they are over 300 on their blood glucose, too high. If they're under 70, too low. All right. Quick question, pop quiz. What are some signs and symptoms of hypoglycemia? Shaking, irritable, sweating. What is type 2 A1C's threshold level minimum to be considered diabetic? 6.5. Good. Pre-diabetes level, 5.7 to 6.5. Exercise will do what to blood glucose? It will lower blood glucose. It's taking that blood glucose and replenishing your source of glycogen. Signs of blood glucose might be too high. Typically, blurred vision, thirst. Dehydration increases hypo or hyper? Hyperglycemia. What is a good snack? Milk's a great snack. It's liquid, they can digest it, but who's going to really carry milk around? So we got to find a good snack for them. A lot of people have orange juice or something fluid that they can intake. What is the optimal pre-glucose level? Anywhere from 90 to 250. When should resistance training be done in a workout? First in the workout. Any good snack would be something that has about 10 to 15 grams of carbs. So you don't want too much, but 10 to 15 grams is usually in there. So hopefully all of these things you know. All right. After about 6 months of exercise, if a client has lost about 5% of their body weight and their A1C is less than 7%, they will likely be able to maintain or decrease their dose of diabetes. So this is a good thing. So and it doesn't happen overnight. We got to go 6 months. They got to check in with their doctor. They got to work with their doctor to maybe even adjust their medications. We talked about some of these complications of diabetes, but kind of going back to them. Peripheral neuropathy results when there's decrease in pain sensation and a higher pain threshold in extremities. So they might, again, not feel that little stone or pebble in their shoe because they have less pain sensation. Retinal neuropathy is characterized by the damage to the blood vessels in the tissues in the back of the eye. So, peripheral neuropathy is a risk. I want to circle back. Peripheral neuropathy. There's a risk of skin breakdown and infections, such as foot ulcers. And sometimes there's what we call Charcot joint destruction with some exercises. Charcot foot is caused by a bone disintegration and trauma leading to foot deformities. So it is one of the most serious foot problems that is faced by patients with type 2 diabetes. They literally have deformation of the foot because of the trauma that's going on. Remind clients to check their feet daily, looking for lesions, blisters. Consider non-weight bearing activities such as rowing, cycling, or aqua. Recommend moderate intensity walking with proper footwear. Even going to some shoe places that have an analysis that will get them the right kind of shoes. We want them to get up to 150 of moderate physical activity. Evaluate balance and include challenges to balance as part of their exercise plan. So again, because they are losing some of their proprioception, it's really important. Be careful if they have retinal neuropathy. Do avoid vigorous activity or resistance training that you hold your breath. Medical clearance. If they say they have retinal neuropathy, you need definitely to check with their doctors. Keep it low intensity. We don't need any more pressure on the eyes. We don't want to do anything there. Autonomic neuropathy, patients should undergo a cardiac evaluation if engaging in physical activity greater than light level. So the autonomic neuropathy decreases cardiac responsiveness to exercises, postural hypertension, impaired thermoregulation, impaired vision, and greater risk of hyperglycemia. So those are things we definitely need to work with the physician of what you can and can't do with a patient. Another link between diabetes and osteoporosis. Both diabetes and hyperglycemia significantly impair osteoporosis and osteoarthritis. So we got to keep an eye on folks who have this. There might be some nerve damage, weak muscles, vision problems, all that. When we start decreasing muscle mass, we will also decrease bone mass. So 50% of those with OA have some kind of diabetes. Again, it's linked with age, obesity, inflammation, leading to joint pain and other mobility issues going on. So do be aware that, again, they could have that comorbidity. We cannot hit on foot care enough, right? So check your feet. Make sure that they're buying wicking socks or wool socks that prevent kind of friction. Really important. Invest the money in good socks. Include non-weight-bearing activities. We want to keep, that friction off the feet. So if you can do that. Soaking can dry out skin and may cause the risk of foot problems. So sometimes they feel like they want to soak. They need to talk to their doctor about appropriate soaking, because we want that skin to be dry. If you think about, the little, if you soak your feet, which feels wonderful and great and all that, but then it kind of might cause some problems. So definitely tell them to talk to their doctor about that. Shoes should be comfortable, 1 to an inch between the longest toe and the end of the toe. We need nice, good toe boxes. There are certain shoes that are great for diabetics that have wide toe boxes for them. And then proper footwear for exercise and lifestyle, just to prevent any kind of reducing the risk. Fluffier, bigger Hokas are not a good idea. Yes, they think, oh, this is so much cushion, but it could increase one's risk of falling, because if you move laterally on running shoes, it's not a good situation. So I would be very careful, especially high drop shoes for them. We need flat shoes so they reduce their risk of falls. Common medications. Obviously, folks who have diabetes are taking some kind of insulin, whether it's injected, automated, all that different type of thing. Understanding The timing exercise has a glycemic response, so check that exercise is being adjusted. So again, working with the doctor, telling them, okay, you need to tell your doctor, we've hit the 3-month, we've hit the 6-month, we've hit a year, I'm increasing intensity. Some of those things to help them kind of regulate their medication because they can go down. Those who tend to be hypoglycemia, check the medication team about potentially adjusting, especially if their blood glucose is under 90, which is, they might just be hovering there. So maybe it's time. And again, you want a full list of what are they taking, because a lot of times diabetes doesn't come by itself. There's other comorbidities going on. Again, when to refer, remember, it makes sense if they have uncontrolled hypertension or blood glucose levels. If you're noticing their blood pressure, blood glucose levels are a little bit off. If you're starting to notice some mobility changes, muscle weaknesses, difficulty performing normal tasks that they did before, if you start noticing some of their sight issues, or if they have specific questions about, some medical questions that are out of our scope, you definitely want to refer out. Sometimes the behavioral care team is needed, if they're not adhering to their program, if they're not maintaining, or, sometimes they just let their blood glucose go crazy and they can't do it. It's high risk for them. We need to figure out what else is going on. So a lot of times, as I mentioned, they're going to have some kind of depression, psychosocial things going on, anxiety. So you want to get them to the right healthcare. A lot of times in the business, we could say, I've had, other clients who struggle with diabetes and they found it easier to talk to, a counselor about it that helps them, put everything in perspective. Maybe, I could refer you, or just something to that effect, where it's not, oh, you need to go for help, but this is common with this condition, so they don't feel too overwhelmed. Okay, I know it's a long presentation and I'm hoping that you took many breaks. Let's do one more situation. We got Richard, who's 51. He travels every month for work. He's managing properties in Hawaii and Nevada. He's motivated to make changes about his health, but worried about his ability to exercise. His home gym condo has a small gym, but he's unsure how to get started and what to do. His doc wants him to have bariatric surgery, but Richard wants to try lifestyle changes to avoid surgery. He has joined a nutrition-based weight loss program, and he says it's going okay. He complains about sleep apnea, knee pain, and some foot neuropathy. He has experienced episodes of hypoglycemia and hyperglycemia. He's not regulated very well. Especially when he's traveling, he would like to learn more about how he can control his blood glucose and learn how to lift weights and use the bike, but he's unsure of what to do. He really hopes to avoid surgery and someday be able to pull his airplane tray down flat on his trips. His belly's impeding. So looking at his stats, he is 6 foot tall, 360, his waist is 45, his BMI is 47, his heart rate's 74, but he's taking a beta blocker, which we know reduces that. His blood pressure is 164. 164 over 64, controlled with medication. His blood plasma is 160. His A1C is 7. His HDL is 36. His triglyceride is 220. On his test, he's below average norms in upper body flexibility, balance, upper body strength, and lower body. He was unable to perform sit to stand. And he found it difficult to transfer from chair to scale and walk slowly, but had a steady gait. Okay, what questions might you want to ask Richard when developing his exercise program? Maybe about his travel. Is he traveling once a year, once a month? What does this travel look like? Maybe, what are you currently doing? You know, can I see your phone? How many steps do you have on there? Does he have any tracking devices? I love the tracking devices. Those really tell a lot. Has he engaged in any diabetes education? Does he have access to diabetes education? What are his concerns about falling? Is there any situations that he has already fell? Is there any concerns about that? So what strategies might you use to implement his program? So he's on the road. He's got to be familiar with a typical hotel gym. So you might say, hey, let's go to local hotel gym and let's look at the equipment they commonly have in there and what can you do? So they'll bike. Okay, well, how do you set up a bike? Well, we always want to do hip distance. We want to make sure it's comfortable. This is how one bike works, not on all of them, but maybe you could kind of show them some basics there. You could give them, a big six program of let's, if you're going to do a workout, let's just do all body parts. Let's, do our big six and, you could do it body weighted because again, he's got some, he's 350 that he's got some weight on there. He doesn't need to throw any more weight, and especially if he has knee pain and all that. So just getting him to move through range of motion and getting him down to the gym would be important. And doing that resistance training before. And, showing them, some strategies and then, eating on the road of, okay, you're going to eat out. So what can we do to make, what do you normally eat? And how can we adjust that? I mean, we don't want to change everything because he won't stick to it, but we can make small changes that can have a profound impact. So he might love his Dr. Pepper, right? Okay, well, how about Dr. Pepper is just for Fridays? And during the week, if you're good, you can earn that Dr. Pepper. But let's drink water between there or lemon water. Oh, that's not good for the teeth. So different strategies there. I know it was a lot. I know you get a whole nother hour presentation to watch, but you can get through it. Again, hopefully this is hitting the same things over and over and it's sinking in because it has to be second nature to you. If you have questions, you can ask me in class, or if you're really dying to ask me, just send me an email. I'll answer them. We are going to hit stop sharing. We are going to hit stop over here, and I'm going to put this up.